Good morning, everybody, and welcome to the International Collaboration Conference on Population Health and Wellbeing Research. Welcome back to those who came to the conference yesterday, and welcome if you're joining for the first time today. The conference is hosted by the National Centre for Population Health and Wellbeing Research and funded by Health and Care Research Wales. The two topics today of focus are children's schools and education and maternal and child health. And the conference programme will work the same as yesterday, and the fact that we've got three really exciting plenary sessions this morning, then a series of parallel sessions where you can break out into rooms. Supporting all of this is the Crowd platform, and there are examples of funding opportunities linked to the topics that we're talking about today and potential opportunities for collaboration. So by the end of the conference, we hope to have made new connections, new networks, with opportunities for new funding and potentially, hopefully, some new grant applications. I'd like to, first of all, welcome our funder, our Director of Research for Health and Care Research Wales, Professor Kieran Walsh, who'd just like to say a word of welcome. So Kieran, thank you very much, and it's great to see you.
Many thanks, Jane, and I'll just add my welcome to Jane's to everybody attending the second day of the conference. It's a great pleasure to have you all here. I'm Director of Health and Care Research Wales, which is the government agency or the part of Welsh Government which funds health and care research in Wales. And my day job is as an academic, a professor at the University of Manchester, and as a health services researcher primarily. In the UK, we spend about £8.5 billion a year on health and care R&D. About half of that is spent by industry and about half by government and charities. It's our largest area of civil R&D by quite a long way in the UK, and it's an enormous investment. And I think the last couple of years have encouraged all of us to have a really careful think about the value of that investment. In many ways, the last 2 years of the pandemic have been a golden period for health and care research because it's been at the forefront of the public consciousness. It's seen enormous investment, and we have seen some huge triumphs, which we should pay some tribute to, particularly in areas like therapeutics and vaccines, and in the way evidence has been used and synthesized and brought into action far more quickly, perhaps, than in traditional scientific models. On the other hand, I think we've got some lessons to learn from the pandemic, particularly in the area of public health and well-being, about our understanding of behavioural interventions and the way in which they work with populations, and about some of the areas of science that are important but not very sexy and therefore perhaps get somewhat neglected. We knew much less at the start of this pandemic about boring things like aerosol transmission of viruses, about really basic technologies like face masks, and about how people would respond to some of the non-pharmaceutical interventions that have been deployed. There is this week in Nature a really interesting commentary. The lead author is Soumya Swaminathan, who's the chief scientist for the World Health Organization, and it's got a bunch of authors who are a kind of who's who in global health. And the title of the commentary is Rebooting Biomedical R&D in the Global Public Interest, and it makes, I think, some really interesting and important points that are very relevant to the audience and the community for this conference. It argues that market pressures and industrial incentives distort our health and care R&D system, that we're not good nationally or internationally at really framing research priorities around research needs, that we need to rethink the balance between curiosity-driven research and needs-led research and learn from the way in which strategically, both in this pandemic and actually in some past examples, the intentional deployment of R&D to focus on particular needs can drive innovation much more successfully and more quickly. And it argues for a much wider view of health and of the public interest in health and well-being. I think it's a really important contribution to the debate. The fact that we're having this meeting online and that most of our meetings over the last 2 years have been online is just one demonstration that we can do things differently after this pandemic. And there's an opportunity for us to learn and to reframe the way in which we think about health, public health, well-being, and the research and innovation agenda. this conference is a great opportunity for that debate to be continued. So again, welcome very much to the conference. Hope you really enjoy the day, and I will hand back to Jane.
Great, thanks very much, Kieran. It's really interesting to hear what's going on and your perspective on it. We've got 3 great speakers lined up now for the plenary sessions. More and more people are coming online, so it's delightful to see you. I can see that people are joining from all over the globe, which is great. I'm going to ask you to put your questions in the chat for the 3 great plenary speakers, or the 4 great plenary speakers in 3 sessions. And I'll summarise those questions and put them to the panel in a short session at the end. So please don't be afraid to put your questions in the chat. So let's move on to our first speaker. This is a really exciting talk on schools and education. I'd like to welcome 2 speakers, actually. Professor Kevin Dazenzienski, I hope that's how you pronounce it. He's Professor of Health Communications in Fulda, Germany, and Professor Orkan Okan, who's Professor of Health Literacy in Bielefeld University in Germany. They run a program on health literacy in schools in 24 countries, and their session is entitled Health Literacy in Educational Context, an Asset for Health Promotion and Achieving Equity. So Kevin, welcome. And I'm sorry I couldn't pronounce your name very well.
Thank you very much, Jane, for the kind introduction. My name is Kevin Dazenzienski. It's a Polish one, and I'm really happy to be with you today morning. As you already said, I will do this lot together with my dear colleague Orkan Okan from Technical University of Munich, also in Germany, and we would like to speak a little bit about health literacy in educational context. And we see health literacy as an asset for health promotion that is able to achieve health, well-being, and equity. Let's start with health promoting schools, or with school health promotion, as this is the much older concept compared to health literacy. Health promoting schools, as you all know, is a very complex phenomenon, a very complex intervention framework that goes much beyond individual behavior change, by also focusing on organizational change, by including the social environment, by including the built environment of the school, and also taking into account the core mission of schools, which of course is health, not health, but more the educational core mission, so educational outcomes. The World Health Organization has favored the health promoting school since its very beginning, since the adoption of the Ottawa Charter in 1986. And what you see here on the right side of the slide are the core dimensions or the core elements of the health promoting school. And this approach is pretty complex because it strives to provide a healthy environment, but not only a healthy environment, but also a school health education, school health services, along with school community projects and outreach. It tries to involve everyone in the school, but also those outside the school setting, including the school personnel, families, of course, the pupils, community members, etc. And as you can see, this approach is a very complex intervention approach. We have on a European level the European Network on Health Promoting Schools, which has been transformed into the SHE network, which is the Schools for Health in Europe network. And the SHE network has organized a couple of conferences on a European level. And the last one was the 5th European Conference on Health Promoting Schools, which took place in 2019 in November. And as one of its core outcomes, it was the so-called Moscow Statement, which emphasized that new approaches such as health literacy, but also existing approaches such as the life skills approach, should not compete each other, but should complement each other and should be integrated in the holistic framework of the health promoting school approach. But first things first, what is health literacy? And I'm pretty sure you're very familiar with the concept. And although there's no common definition of what health literacy really is, I will give you a definition which is the result of a review by Sørensen et al. And Christine Sørensen and colleagues see health literacy as the knowledge, motivation, and competencies to access, understand, appraise, and apply health information in order to enable healthy decisions in everyday life. And as already said, there is no commonly agreed understanding of the term. This is one problem, and the other problem is there's still a lack of conceptual basis. But however, I see a clear transition from the concept which comes more from, let's say, a functional, narrow understanding, including reading skills or numeracy skills, to a now more broad understanding, which includes these 4 core dimensions: finding information, understanding information, evaluating and applying health-related information. While we have a very good empirical basis for adult target groups or for adult groups, we see that children and adolescents, or research on health literacy with children and adolescents, is still in its infancy. The same holds true for the education context of schools. As we have equity in our title, we see that health literacy is characterized by a so-called social gradient. And here's one example why we see that. This is a German example of a study that we conducted in 2019 before the corona pandemic. And this focused more on digital health literacy. And you see that the students or the pupils from 8th and 9th grade that report to have a low subjective social studies also tend to have a low digital health literacy in these 4 dimensions of searching and finding health information, adding self-generated content, evaluating reliability, and determining relevance. We see also some gender differences with girls having a lower digital health literacy, but we don't see any differences with regards to grade and type of school. When it now comes to health literacy and schools, we should, and this is one of the core messages of my presentation, we should align all activities to the holistic approach of the health promoting school. And when you do so, you can come up with a framework which could look like this one here. The first dimension refers more to the curriculum level, which includes, amongst others, external programs to promote individual health literacy for pupils, but it also strives for systematic integration of health literacy into the subject areas in curricula. Orkan will tell you about that in some minutes. The second dimension includes the school staff, and school staff includes 2 dimensions. The first dimension would be that we need to equip to support our educators with the skills that are necessary to train and teach health literacy on, for example, on a curriculum level. But on the other side, we should also focus on the health literacy of teachers and educators themselves, as the studies tell us that a huge amount or a substantial amount of teachers and educators have difficulties in finding, understanding, appraising, and applying health information for themselves. The third dimension includes the school environment, and this includes all activities that try to integrate health literacy in health promoting school development. We call this approach more organizational health literacy, and we can learn a lot from the healthcare sector, and we can transfer their experiences to the school, and Orkan will also focus in his presentation on the school environment. And finally, we should also look at the wider school community, as we know that schools are only one setting within a broader picture, within a broader community. And this, of course, should include any activities that foster network building, cooperation with community stakeholders, and also parents. I'm not able to concentrate on all of these dimensions right now, but I will focus on dimension 2, 3, and 4. Let's start with school educators or school staff. As already said, the amount of or the study findings are really limited, and these are 4 study findings indicating that pre-service teachers as well as headmasters have also have the same problems and report difficulties in finding information with regards to health and dealing with these kind of information. These are studies coming from Iran, Ahmadi and Montaseri, or Germany, or Sri Lanka. The last one is a study that we have conducted also in 2019, shortly before the corona pandemic, and it said that school headmasters or principals do have also the same problems. 30% of our sample had some problems in dealing with health-related information. More specifically, we find that with increasing age, the health literacy of school principals also increased, and principals mostly reported difficulties with assessing the reliability of health information and with finding information on how to manage mental health problems. And the last finding is very important, as you could also find that health literacy is also very much related to mental health of school principals or headmasters. As you see here, those reporting a limited health literacy also tend to be affected more often by a low mental health status, for example, low well-being. They are more often affected by emotional exhaustion or psychosomatic complaints. And the difference here is really substantial and takes up to 20%. So it's really substantial. So what means that we should also focus on the health literacy status of educators, and we should promote our educators to gain better health literacy. Let's move on to the organizational level. It's very important to keep in mind that health literacy is also associated with the implementation of any health promoting school measures. And we also focused in our studies on this issue. And what you see here is that those headmasters reporting a limited health literacy also tend to report less activities with regard to school health promotion in their school. So the implementation status is lower, and the difference is 10% here in this study. And taking it a little bit more complex, you see here the results of some regression analysis, and taking into account all these different facets, gender, professional role, type of school, attitudes, etc. You see that health literacy even predicts, or is a significant predictor of the implementation status of health promoting schools, even after controlling for all these factors that are displayed here. Okay, and the last issue that I would like to concentrate on is the wider school community. As already said, schools are one setting within a broad community, and I would like to introduce a project we are working on since 2019, which tries to strengthen navigation health literacy. Navigation health literacy is a sub-dimension of the broader concept of generic health literacy, which is the ability to find, understand, evaluate, and apply health-related information in services provided in or by organizations or health professionals in the person's personal vicinity or environment, which means that it captures the ability to find local organizations, professionals, and their services to understand what these organizations has to offer with regard to health, to evaluate the quality of these services and organizations, and also to assess which health-related service might help in a specific situation. We try to promote this navigation health literacy in young people, adolescents, and young adults by developing this app Nebulous. And Nebulous, as you can see it here on this screenshot, is a kind of location-based game. It allows us to create so-called digital-based exploration rallies to give young people the opportunity to get into contact with local stakeholders in their services. We are doing that together with schools, with local organizations, for example, as part of school project weeks. And we use some elements from the entertainment education approach. The main idea behind this is to provide a fictional story that is told from the perspective of young characters through voice messages. To give an example, this story could be a crime case, for example, and our users have to solve this crime case, and to find some hints to solve this case, so have to go into contact with local stakeholders to find those hints. We use certain game elements, for example, culturally and gender-sensitive avatars. We use interactive maps, as you can see it here on the middle screen. We use a story, hidden stations that can be found and explored, and we also provide some kind of rewards, for example, badges. And the most interesting part here is that not we as experts or as academics do create these kind of exploration rallies. These are the local stakeholders and organizations themselves who are developing these rallies. And to allow this, we provide a kind of browser-based planning tool that you can see on this screenshot. What it takes, or what it needs, is a caretaker, someone who takes over responsibility on the local side and coordinates such rallies. And he would, for example, use or establish new local networks together with schools to develop those kind of location-based rally. In Germany, we have some examples with schools where pupils in participatory workshops create rallies together with local coordinators. No specific IT requirements are necessary. When you can use Word, of course, you can use this enables planning tool. And the most important part is that we are now able to deliver or to create location-based rallies based on the local needs. And it can be done worldwide. It's not limited to Germany, although this platform and this project is only available in German language, but we will, of course, translate it into other languages as well. So to sum up, in a nutshell, I have 3 arguments to share with you. The first one is that health literacy, of course, you know that is really high on the agenda of research and policy. However, health literacy should not be introduced as a separate topic, at least to schools, as schools are very much overwhelmed by all different topics. So instead, we should include health literacy in the holistic frame of the health promoting school approach. I said that we need more research when it comes to health literacy in education context, and also in the area of health literacy in childhood and adolescence. For example, we know very little at the moment about the relationship between health literacy and educational outcomes. And here as well, Orkan will tell you about that one in a second. And I said we should align all activities to the core dimensions of the health promoting school approach. And I introduced 4 dimensions: the curriculum, school staff, school organization, and the wider school community. Thanks very much. And I now would like to hand over to my dear colleague, Orkan.
Thank you, Kevin. Good morning, everyone. Yes, the presentation. Oh, yes, there it is. So good morning, everyone. My name is Orkan Okan. I'm from Technical University of Munich, and the presentation you're going to see pretty much draws on the topics Kevin set the floor for, theoretically and empirically. I will in particularly talk about a classroom-based learning program for strengthening health literacy and a whole school approach, the organizational health literacy approach in schools. So you have just seen the definition of health literacy that we are using by Sørensen et al. But in addition, we understand that health literacy is not only a behavioral, but an environmental, structural, systemic concept, which is relational, and one has to take into account the complexities of the environment, which is especially true for schools, which is why the organizational health literacy of schools is so important. And of course, children and adolescents are an important target group because interventions work better if they are implemented early, which is shown by the figure that you see here on the right-hand side, and on the left-hand side, you see some of the reports that we have together developed for different organizations working with schools on health literacy. And you can also see the Alliance for Health Literacy, which I will be introducing on my last slide. So when we go into the main findings of these reports, we can see a couple of them that reoccur almost in every country. First, health literacy is very new to schools, so it's a brand new topic. There is no mandatory school curriculum for health literacy, of course, and only very few countries have a policy, an educational policy or health policy. And even most countries don't have school health educations. For example, in Germany, there is no such school subject as school health education. And this also means for Germany, but for many other countries as well, that teachers are not being trained in matters on matters of health. So they are not equipped with the skills and with the knowledge that would be required to teach health literacy in the classroom. And if we sometimes are successful to bring our health literacy projects, our programs to schools, it is quite difficult to implement them because schools are already overcrowded. The whole curriculum with the mandatory school topics, with project days, etc. So there's almost no time to address non-curricular topics. As such, health literacy is not a curricular topic. So these things make it quite difficult for us to bring health literacy into school. So one has to seek for other solutions how to successfully address health literacy in schools. Before I introduce two such concepts, and of course you have seen some of the examples provided by Kevin, in this figure, you see an evidence synthesis that we have undertaken for the Schools for Health in Europe framework. And you can basically see here how health literacy directly can influence health-related behavior and health conditions, and how this is influencing educational outcomes. And on the other hand, we all know from health and education research of the past 20 to 30 years that education is also a predictor of health outcomes and health behavior, and also an important determinant of health literacy. But keeping in mind the relational concept of health literacy, we have to closely take into account the structural and contextual factors that enable all these other areas. So this is where our work is mainly focusing on the school age, which is a very important starting point for interventions. And as you can see, on the one hand, we can address curriculum, but most of the items that we suggest are related to the whole school and the environment. And of course, the past 2 years have shown us that COVID has also an impact on health literacy, and health literacy can be useful to deal with the sheer amount of information to navigate communication and services in times of uncertainty, and especially also take part in risk communication, understand behavioral recommendations, evaluate online health information, and help distinguish between good and bad information. So there is a health crisis, and it perfectly shows what health literacy is good for. Also, being important to children, also being a topic that can be addressed in schools. So, and I want to introduce the first of the projects. This is the classroom-based health literacy program. And as I said, there is no item in the curriculum addressing health literacy, but there is one on digital literacy. And this is the one I'm showing you right now. This is mandatory for all schools in Germany. There is an initial budget for all schools to invest in their curriculum, in their staff, in their infrastructure to prepare schools for the digital age. On the state level, you know, Germany is federally organized. We have 16 states, and education is responsibility of each state. So each state uses this digital literacy curriculum, but on the state level, this is named media literacy because media literacy has a long tradition in education in Germany. But practically, it is absolutely the same curriculum, which looks like that. We have 6 dimensions, the second of which is directly related to health literacy, and the others are to communicative, to critical health literacy, to information technology and digital media. So what you see here is something that is mandatory in the school and is already being addressed. And so our aim in the Tool HLCA project was to develop an intervention that is embedded within this curriculum. And since health literacy and digital literacy or media literacy share so many intersections, it was very easy to develop an intervention that is addressing these interventions. And so teachers, when they address digital literacy in Germany, there is no requirement to address digital literacy with a certain topics. The whole topic is so new that they are happy to receive any topic. And our topic is health, in this case, health literacy. And so we provide teachers with this intervention. And when they have to address media and digital literacy, they do so by using the example of health. So, and with this, we managed to overcome all these barriers that I just introduced in the introducing slides. Let me skip to the next project, to the Health at Schools project. This is the whole school approach, the organizational health literacy approach. We have developed 8 standards with each 6 indicators within the standards to describe the organizational health literacy capacities available in the schools. This also includes the students' health literacy, but the other 7 dimensions are mainly addressing infrastructure, stuffs, networking, etc., etc. By using these standards, schools can assess the available health literacy capacities in school and learn how they are doing, see where they can improve or see where they are good, and also make themselves health literate. So that's an approach that comes from systems thinking level, and I believe is very important that we understand health literacy not only as a behavioral construct, but also as a structural construct. And as Kevin has highlighted, there is the health promoting school that is been around since the mid 1980s. And this is also a whole school approach, like the organizational health literacy approach, which is being used in Germany. So it makes no sense to us to introduce in parallel another whole school approach, but to think about ways how we can integrate the one into the other. And this is also something that you have seen in Kevin's slides, that it could look like that. The white squares that you see in the middle are the health literacy standards, and the bigger blue squares are those related to the health promoting school dimensions. And you can see this could be how an integration of health literacy into the health promoting school approach could look like. You can also learn more about this kind of ideas, not only by reading our SHE fact sheet, but also the SHE report on health promoting schools, which was just published in the second version earlier this year. Right. And of course, in the project, since teachers always will ask for interventions on the classroom level that they can implement there, as part of the project, we have also developed a toolbox, which you can see on the left-hand side. And below that, you see all the interventions. And then teachers can check the interventions, what kind of health literacy interventions are available. This is only for German-speaking regions, and they can pick one of the interventions that they might use. For example, on the right-hand side, you see the Toolbox Health Literacy, the other project that I just mentioned. And there are many more interventions. The Nebulous intervention, the digital app that Kevin just introduced, is also part of this box. And so the box provides a variety of methods how to strengthen health literacy. So, and last but not least, I already mentioned earlier that we have launched an alliance for health literacy in schools in Germany. And last year at the IUHPE and ILAC conferences, we have gone global with this alliance, the Alliance Health Literacy for Schools. And the main aim of this alliance is to translate research findings into school practice. So speaking, summarizing it in only one sentence, of course, we want to advance the evidence base. We are providing strategies for implementation, further develop them, and also advocate for health literacy in schools as much as we can. You're welcome to join. Some organizations already joined. A lot of researchers, practice partners in Germany and internationally have joined us with the overarching goal of translating research and building capacity. So it would be nice if we could hear from the one or the other of you to join this alliance. All right, thank you so much. I'm happy to receive your questions.
Okay, Kevin and Orkan, thank you so much. Your presentation was brilliant, and Becky in the chat has asked to make sure that she's got access to it and to just let everybody know that the presentations and the slides will be on Crowd afterwards. We've got just a couple of minutes because your timing was absolutely excellent. So I'm going to just relay just a little bit of feedback to you, and then we'll come back to questions in the joint session later. So Sue says, really interesting to think about health literacy of staff as well as students, and that's really important. We've heard about health promoting communities. Now it's really great to hear about health promoting schools. And clearly in terms of health literacy, safeguarding comes into that as well. Sam had some thoughts on teacher education being key. We'll ask you later about justifying health literacy into a very busy timetable, although you went on then to cover that you sort of tried to sneak it in as under digital literacy, which is a really great way of doing it. MC hopes that health literacy may gain equal status to literacy and numeracy in the curriculum, and thought your presentation was great. And Sam commented that there's no mention of physical literacy, i.e. sports and exercise. Is this because physical literacy sits outside health literacy? And then Mark has just come up with a question. Interesting talks, thanks. Do you think the media also has a role to play? So I don't know whether Orkan and Kevin, you want to answer the last question, because we just have a couple of minutes before our next presentation. Do you think the media has a role to play? Who'd like to take that?
Questions,
based on our presentation. Yeah.
So we'll double it a little bit. Orkan, please go on.
Yeah, very short. I believe the media has a role to play because social media is part of the whole socialization and development process of children, and we have to make sure that we get them on board.
Yeah, I absolutely agree. Thank you for that. And for Kevin and Orkan, that was an absolutely superb presentation. Your slides were such great quality, and it's really good to hear about the evaluation you're doing as well. And I'm going to ask you to think for the session we're going to do on questions later. Can you start thinking about what do you think are the key research questions that need addressing? Because we want to think about the future research agenda and where we might look for some funding for these types of questions. So if you can put your heads together for that while we listen to the other presentations. So it's time to move on in the programme. So thank you to Kevin and Orkan. You've set a very high standard for presentations. So we're moving on to Hayley Christian now. So no pressure, Hayley, but that was a great presentation to follow. And welcome to Associate Professor Hayley Christian, who's based in the University of Western Australia. Hayley leads the PLACE programme, which is Play Spaces and Environments for Children's Physical Activity, Health and Development. And it's a programme of research, and she's head of the Child and Physical Activity, Health and Development team at the Telethon Kids Institute in Western Australia. Her presentation is entitled The Influence of the Built Environment on Child Health, Australian Research. So Hayley, I've no idea what time it is for you, but I hope that you're feeling energised and have got coffee on board, and welcome so much to our conference.
Great. Thank you so much, Jane. No, I don't have coffee. It's quite warm here, so just water. Thank you very much for the opportunity to present today. It's my evening, but I still have the energy to get through and share some really great research with you around the built environment and child health and development and the Australian context. So I just need to acknowledge that I am on Noongar Whadjuk Budja and pay respects to our elders past, present and emerging, and thank them for the generosity and the wisdom in the research that we do here. So what is the built environment? Well, it's all around us. It's many things. It's generally defined as man-made, but it can be natural environments for which humans carve a pathway through, for example, so in many of our nature areas. But it's where we live, it's where we go to school, it's where we work, it's how connected or not connected we are in terms of our streets and access to very many destinations that we use each day or on a more occasional basis. It's our traffic, our active transport options, it's crime, it's safety, it's access to food, whether they're good, healthy or unhealthy food outlets. It includes recreational destinations, and the built environment includes things as simple and micro as footpaths. Because where we live matters. Our proximity to our house to town centres, to job markets, to transport links, the real social mix of the community, the provision of public amenities like parks, healthcare, schools can critically impact our individual well-being and health, but also the health and well-being of our communities. So this is probably a good example, I think, the most contrasting example I can give you of supportive and unsupportive built environments, particularly around walking. So here's a park that you may have near you. It's not that pleasing in terms of going for a walk, even if you're taking the dog. Would you prefer this one, Park A, or Park B? Big difference, chosen them on purpose. But the second option here, obviously a lot greener, a lot more vegetation for places like Australia and Perth, where I'm based. That tree canopy and shade is critically important. There's markings there for supporting different sports and activities. There's a shared pathway. Really big difference in how these, man-made still parks can either support activity in particular, or even building of social capital and sense of community through using these spaces. So I've popped this up here. I'm sure many of you are very well aware of it, kind of our social determinants of health model and all the different levels of influence. I've just put it there to remind us that where the built environment sits in terms of health and well-being and outcomes. Yes, it's not right there at the centre in terms of individual and lifestyle factors, but it's around the periphery. And the key thing here is that, particularly around the built environment and infrastructures, if we get them right, we get them right for a long time, even though the influence may be quite small on our health and well-being. But if we get it wrong, we get it wrong sometimes for generations, and it can have a slow negative cumulative effect, negative effect on different health and well-being outcomes. So in terms of the built environment, where does it sit in terms of its importance? I don't think you get much better than the US Surgeon General saying that, it's one of the best buys for promoting physical activity. So we know that those environments and so forth are really critical. And, it's about creating those environments that make it an easier option for people to be physically active. And I probably didn't make it clear up until now, but in terms of the built environment, a lot of the research that I will present to you, has really come out of the physical activity space, going back a fair way, but there's lots of other health outcomes, obesity, and some of the work we're doing and others around child development, where the built environment has a very important role to play. The World Health Organization also has, creating active environments as one of its, key objectives for decreasing worldwide physical inactivity levels. And this is also about equitable access to safe places and spaces within our communities across the world. And in terms, again, of physical activity, our lead organisation or professional association, the International Society for Physical Activity and Health, have, in the last couple of years, put out 8 investments that work for physical activity. And this is, again, at a country level. And you'll see across the bottom there of the slide those key 8 investments. And right side by side there, active urban design and active travel. You could even throw in, the built environment angle around sport and recreation for all as well. And lastly, in terms of setting the scene and the importance of the built environment in what we do in population health, is probably no better to get a series in the Lancet. So this was the 2016 series. I believe there might be one coming up on the agenda soon as well. So, in terms of academia, it's certainly got its prominence, and the field has, rapidly taken off in the last couple of decades. All right, I suppose if we look at chronic disease and prevention of NCDs, just again, a very simple figure we're all probably quite very familiar with, but just highlighting there, in terms of death and disability and those key chronic diseases, yes, we have a whole lot of physiological risk factors that are important, but sitting behind them, influencing them, are the modifiable risk factors like physical inactivity and healthy and unhealthy eating and so forth. But then sitting behind them, influencing our decisions around what healthy behaviours we may or may not do, sit things like the built environment. All right. So in terms of the built environment, we measure it in many ways. If we're lucky enough, we have our own geographer within our public health teams, but quite often we work with other disciplines, such as geography, to create objective measures of the built environment. And these you see on the slide are probably just some of the standard measures. So it can include things like walkability, cyclability, now livability, it's exposure to traffic, any kind of destination you think of, really. It's vegetation, greenness, it's the connectivity and the density of our housing and areas that we live in. It can even bring in measures around crime statistics or perceptions of safety, and it's also about the aesthetics or the attractiveness of where we live, work and play. Oops, gone ahead. Too many. I just shared this figure as well because this probably extends a little bit more of our basic figures around, or theoretical models around the influence of the built environment on health and wellbeing, and tailors it specifically to the early years, so that first important 5 years of life, and different, I suppose, health behaviours, but then the impact that may have through to development. So I think when we focus our research on especially the early years, it's understanding the neighbourhood environment. Childcare centres become important and their spaces, the home environment. So these more micro built environments become really important to understand their influence on those opportunities that children would have for play, active play, social interaction, and then the impact that then has on really key early developmental milestones and outcomes for young children. So this is kind of a very basic, yes, very linear type model that we've been using to guide our research initially in this space. So just in that kind of introduction to children and the built environment and some of the measures, I just wanted to share with you a pretty amazing project. This is an international project funded by the UK Research Institutes and the Australian National Health and Medical Research Council. And the call came specifically for built environment and prevention research around NCDs back in 2019. The scheme only funded 5 projects internationally. We're very lucky to be one of the 5, along with our team based at Swansea, and the only team to really try and tackle this area of research from a child's perspective. It certainly has its own challenges in that regard as well. From the Australian team's perspective, and I'm sure quite a number of the Swansea team are on the conference at the moment, these are our partners, our stakeholders. So we've really, made sure that the work we've done leading up to this project called Beaches is to make sure that we're being informed throughout the research process and to really help with that translation and impact. So we have various government departments there, not just the obvious health and planning, a whole lot of NGOs. And because a lot of our data, which you'll hear about in a moment, is around the early years, we have a lot of other organisations that have vested interest in the early years as well. So I think we're now going to get challenged with technology, and I hope in a good way, because I have a little video to share with you which does provide a summary of the built environment and child health in Wales and Australia project, Beaches. So let's see if this works, and if it doesn't,
Built environments and child health in Wales and Australia. The Beaches Project. What is the built environment? And why does where you live matter? The built environment refers to the human-made surroundings that provide the setting for human activity ranging in scale from parks, to buildings, to neighbourhoods, and cities. The proximity of an individual's house to town centres, shops and markets, transport links, schools, parks and healthcare can all critically impact well-being. For children, the nature of the built environment can facilitate more opportunities for play and physical activity. Over the past 4 decades, obesity in children of all ages has increased worldwide. Childhood obesity and physical inactivity are 2 of the most significant modifiable risk factors for the prevention of non-communicable diseases. Currently, over a third of children in Wales and Australia are overweight or obese, whilst only 20% of UK and Australian children are considered to be sufficiently active. So, investigating how the built environment drives obesity in children will enable us to develop evidence-based planning, policy, and practice strategies. Thus, this will enable us to help prevent the rise in non-communicable diseases. The Beaches Project will explore which aspects of the built environment can reduce the negative impacts on children's modifiable risk factors for non-communicable diseases. These factors include physical inactivity, sedentariness, poor diet, and overweight and obesity. The Beaches Project aims to 1. Develop a comprehensive geographic information systems model of the child-specific built environment. 2. Link standardized GIS models of the built environment to cohort data. 3. Determine the direct and indirect relationships between the built environment and the modifiable risk factors for both NCDs and obesity. And 4. Identify how relationships between the built environment and these NCD risk factors vary by socioeconomic position and geographical location. In order to address our objectives, we will be using cohort study data from 5 different cohorts from Wales and Australia. The 2 cohorts from Wales include the Wales Electronic Cohort for Children and the Millennium Cohort Study. The Australian cohorts include the Origins Project, the Play Spaces and Environments for Children's Physical Activity Study, and the Growing Up in Australia, the longitudinal study of Australian children. Overall, the Beaches Project will produce evidence which policymakers can use to modify the built environment, to reduce childhood obesity and NCDs.
Well, I'm not sure what magic happened there, but thank you very much for making the video work. That's great. All right, let's see if we can. There we go. I just thought I'd share this with you just for some. This is a slide prepared by Rich Fry, one of the chief investigators on beaches, and I think it provides a good example of the geographical difference we're dealing with in terms of Wales and Western Australia. So WA is 122 times bigger than Wales, but at least in some of those key demographic variables, there's not too much difference in terms of population and housing, but the geographical scale is quite a contrast. So thanks, Rich, for that slide. Moving along. I just wanted to share with you briefly the 4 work packages. I'm sure you've seen something like this before in your projects, but I do have some findings I wanted to share with you today around our work package 1, which has been a policy review, at least from the Australian perspective. The rest of the Beaches work is really around harmonising our built environment measures across the 2 sites, big EPI package, and of course just continually working that research translation and impact and stakeholder and end user engagement throughout the whole project. So this works package 1 has been, from the Australian context, is been reviewing relevant Western Australian and national policies that address children and young people through the built environment and the influence that the built environment has on those modifiable risk factors. So physical activity, healthy eating, obesity. I'm not going to take you through the methods because I don't have time, and we just have released today this report, and it's up on our Beaches website. So if you want to read more and see the infographic summary, you can do so. But really the key finding in this policy review is the voices of children were not included. There was, I think, 5 out of the 41 policies reviewed a mention of children. And so really when we look at the evidence base to date, there is some similarities in how the built environment influences adult and child physical activity levels, for example, but there are some differences. So, and of course, within children, big differences in some, under 5 versus how a teenager might interact with green space. And of course, differences by background and so forth. About half a dozen other kind of key recommendations. I don't have time. I'm not going to go through them. But if you'd like to know more, check out the Beaches website, which is hosted on the Telethon Kids Institute page. But all our Swansea colleagues have the report, and I'm sure I'd be happy to share it with you if you're interested as well. One of the key aspects, I suppose, in terms of beaches, but also in general when we do built environment and child health research around the world, but I'm definitely saying from a Western Australian perspective, is this significant decline in active school transport we've seen in the last 40 years. So from around 75% down to less than 20%. And this is huge because it's a loss of everyday opportunity for physical activity, that unstructured, even though it's a form of transport for children, it's a huge loss of everyday physical activity that we really need to be doing something about, and we have a huge opportunity to intervene. This is real when we consider, this is 10 years, this data old now, but this is data from a study called TREC, which really did unpack active school transport, at least from a West Australian perspective. And while the levels were so low, when we look at boys, 10 to 12-year-olds, while many didn't walk or cycle, nearly 60% wanted to do so. And again, for girls, not many walking or cycling, but over 50% wanted to do it. So, we've got kids wanting to do it, but there's obstacles in the way. And we believe it's a combination of aspects of the school-built environment and the neighbourhood around those schools, but also, of course, parent perceptions. Just briefly, we've, as part of the Beaches projects, we have this our place cohort study running through, and so we've been able to track from as young as 2 to 5 years some active transport behaviours. This is, for childcare, so about 9% of children would be walking at least one or more times a week to childcare. This bumps up to about 33% once they're about 5 and enter full-time school. And however, we're now in the field collecting a third time point when children are about 8 to 10, and unfortunately we're getting the sense that that's going to drop back down to that 20%. But we're starting to collect some neat longitudinal data on this, at least from a Western Australian perspective. Again, going back to some findings from our previous TREC study, what can we do to encourage more walking and cycling to school when we think about it through the lens of the built environment? Well, it's simple things, but you've got to work with a lot of departments to make these happen. But lowering the levels of traffic and speeds around schools, having more safe crossings, but really importantly, not just saying that we need to have more connected neighbourhoods in general, but connectivity and more grid-like street patterns allow a more direct and quicker route for children to get to school. And as you can see in that example on the left, which is a very unconnected, curvilinear, cul-de-sac type design neighbourhood, that child's not only got twice the distance to get to school and time, but they're being exposed to kind of a major road as well. So it makes sense on so many levels that we're building, redesigning our neighbourhoods to be far more connected. Also happening in Australia, has been happening for a while, is the loss of the Aussie backyard. And for young children that are under 5, this is a really important source of active play, and a safe active play space. Outdoor home environments are looking more like adult entertaining spaces, whatever is left of the little bit of land after we've built our biggest houses possible on the smallest block that's available. So real loss in opportunity there. So as part of our overall place program of research and the cohort study that's part of that, we've been, again, trying to unpack that more and understand what's going on. We're really interested in that neighbourhood, but because our focus in our place research is really on that under 5 age group, we're really looking more closely at those micro-built environments, so the home, childcare centres, and as kids transition into school as well. So just by way of example, this is the place cohort study. This is a baseline, and pretty much this data we've been collecting has continued through. So I'm putting it out there already in terms of some opportunities to collaborate, and any great ideas people have for research questions is, the amount of data that we have there. We try our best to collect objective measures, but we know the value of parents' perceptions around whether it's our outcomes around physical activity, but also the role of the built environment. So I won't go through that, but let me just say there's a lot of data there that we'd be willing to collaborate and share with others with, and use a lot more. Some of the work we've done around outdoor play at home, this is just parent-reported data, so it'd be nice to get our measures of the GIS to be a lot more sensitive for those smaller home backyard spaces, but more outdoor play in 2 to 5-year-olds with bigger yards, more fixed and portable play equipment, and when they've got more natural features. But as I said, we've got smaller yards, bigger houses, and we're building our outdoor areas to be more like entertainment areas for adults. Some of the work we're doing is tapping into some really high resolution imagery data. The arrow pointing there is to an outdoor area in a childcare centre, and what we can see using this vegetation data is the amount of that space that is vegetation. Oops, let's get ahead. And the different height classes. So again, in Australia, shades are really important, and we can look at how much tree canopy coverage we have in our childcare centres. Really important for allowing kids to have as much time outdoors to be physically active. I think I'm just running out of time. I have GPS, so bringing in the spatial data as well. One of our PhD students, Poulan Bai, has been able to look at hot spots and cold spots in terms of children's physical activity in outdoor spaces. Really great data there to bring in as well. And I'm just about finished. One last amazing data set internationally to share with you, and I think would be a real collaborative opportunity, is the Australian Early Development Census. So very similar to and based on the Canadian Early Development Census, but this amazingly is 96% of every child in Australia as they enter first year of school, assessed across a number of developmental domains. There's some of the results there, but really there's opportunities here to link this data with some national built environment measures and unpack the role of the built environment a lot more in terms of early child development. Some of the work we've done already here is showing that the neighbourhood physical environment has a weak but significant effect. And, there's some of the built environment features that are important to early child development: traffic exposure, green spaces, density, and child-relevant destinations. I'm speeding up because I'm running out of time. Sorry. Yes?
Yes. Hi, it's Jane moderating. We're out of time. It's 4 minutes past. So if you wouldn't mind just trying to summarise and finish.
I will.
Thank you.
Good. No worries. No problem. And in summary, and now I have gone, our lights have turned off, the buildings have shut down. Just in summary, an opportunity to collaborate, as I said, on the Australian Early Development Census, incredible data set, and I have finished. So any questions, opportunities, I'm willing to take. Not now because we've run over time. I'm very sorry. Thank you, everyone.
Hayley, thank you so much. That was absolutely brilliant. And there's a lot of buzz in the chat, which we'll go through later. And I'm so glad that the technology worked. So we'll move on to Dr. John Elotti, who works on the women's health and epidemiology in the WHO Centre for Global Women's Health. Welcome, John. I hope that you're lined up. John's going to speak on the WHO Collaborating Centre for Global Women's Health, improving the health and well-being of mothers and fathers to be in their children across the globe. So, John, over to you.
Sure. Hello, everyone. Thank you for the opportunity to speak today. As Jane says, I'm John Elotti, and I'm an epidemiologist in women's health at the WHO Collaborating Centre for Global Women's Health at the University of Birmingham. I just want to say I've come down with a bit of a respiratory virus in the last couple of days, so if I break into a coughing fit during my presentation, I do apologize, and I'll try to speak as loudly and clearly as possible despite it. For my talk today, I'll just be giving a whistle-stop tour and a brief overview about the work we do at the Collaborating Centre, basically going through who we are, what areas we work on, what areas we collaborate in, and explore if there's any potential for collaboration or synergy to collaborate with anyone in this conference today. and look for ways where we can work together on this. So start off by telling you about us. So we're a multidisciplinary team, and we work closely with local hospitals, so we work in close partnership with them. And our primary aim is to end death of mothers and babies from preventable causes. And we do this by carrying out research to understand why a woman and an unborn child can become ill and how they can stay healthy. So our research follows a life course approach. We start right at the beginning of pregnancy, involving mothers and fathers who are trying to get pregnant. In pregnancy, we also investigate early pregnancy outcomes such as miscarriages, and then other pregnancy outcomes as pregnancy progresses, pregnancy complications. And after birth, we follow up the child and carry out follow-up studies of the children, and also the mothers, exploring other health conditions, and this sort of follows on to subsequent pregnancies and leading back up to pregnancy and childbirth, and so the cycle sort of continues. So how do we do this? So we conduct clinical trials, evidence synthesis, prognostic research, multi-census surveys, and qualitative research and implementation studies. And some of our partner groups, so we collaborate with researchers on virtually every continent. And one of our key principles is to build capacity in regions that we work in. And all of this is underpinned by collaborative work with women, their partners, families, and members of the community. Some of our partner groups include Katie's team, which is a patient and public involvement group established in East London in the UK. And then the Hilders, which is another public involvement group in the West Midlands. So members of this group help identify areas of research. They support grant applications and are involved in actual applications as co-applicants. They give critical feedback to applications and to proposals, and also sit on study committees to help direct the study, so give critical input into how the study is run. We also collaborate and work with patient and public groups in the country, in specific countries as well, such as the Action on Preeclampsia charity in Ghana, which is the only charity that looks out for women in pregnancy in terms of their experience of hypertensive diseases in pregnancy. So I'll just go through a couple of shine a spotlight on a couple of projects that we currently run. And the first I'd like to highlight here is our Emotive Trial. So the Emotive Trial is a trial that aims to stop mothers dying from postpartum hemorrhage. And we're doing this by finding effective ways to prevent, diagnose, and treat it. So we have a package of intervention here where we plan to help identify or detect PPH early on, and then the package also involves treatment, effective treatment, ways to treat it, and also ways to prevent it from happening. It's funded by a grant by the Bill and Melinda Gates Foundation. And this is a global trial that's run in 5 countries at the moment, involves 80 health facilities. And the target is to recruit 300,000 women. And to work, to run this trial, we have more than 500 staff employed in these regions. So the next project I'd like to highlight here is the International Calcium in Pregnancy Project, Isip. And this project aims to determine what the optimal calcium supplementation strategy is to prevent preeclampsia in low middle income countries. And we want to find out whether this varies by the characteristics of the mother. So does this vary by the mother's risk status? Does this vary by her age or her parity? And this project is funded by the National Institute for Health Research and supported by the WHO. And it uses individual participant data meta-analysis. And we have data from more than 15,000 pregnant women. And we also utilize mixed methods research in this project, including health economics analysis. We have collaborators from 15 countries, including in Argentina, where the data is being processed and stored. And as I said earlier, capacity building is a big deal for us in our institute. And this project has got capacity building in LMIC regions weaved all the way through. So we're running workshops on evidence synthesis using systematic reviews, IPD meta-analysis, ways to incorporate patient and public, getting the voices and the views of women and their community into research so that it can inform research, but what the kind of research that's being done and how the research is being conducted. The next project I'll just talk on is the Ipec Project. It's the International Prediction of Pregnancy Complications. It was initially funded by the NIHR, and the consortium came together initially in 2015. And the initial objective was to find out ways of accurately predicting and preventing preeclampsia. And so we've expanded since then to include prediction of other pregnancy complications. And this particular project funded by the NIHR and with additional funds by the Stillbirth and Neonatal Death Charity and the Wellbeing of Women, we're looking to see if we can accurately predict stillbirth, fetal growth restriction, and then the baby's birth weight. So the research methods we use here is prediction model development and validation, and we use individual participant data meta-analysis for this. We collaborate with 134 researchers from around the world, from more than 30 countries. And to date, our database has got the IPD of more than 4.5 million pregnancies. So this data repository is again a useful resource for collaboration. We have expanded and also worked with researchers who have applied to access this data and use them for other analysis to do with prediction and prevention of pregnancy complications. And finally, I just want to highlight our work here on COVID-19 in pregnancy, the Pre-Cov Living Systematic Review. And on this project, we are looking at the effect of the SARS-CoV-2 virus in pregnant and postnatal women who are at risk, suspected and diagnosed to have COVID-19. And this project is supported by the WHO. And it uses the living systematic review methods, and we're looking at what the prevalence, risk factors, mother-to-child transmission, diagnosis, treatment and prevention of infection and COVID-19 disease. And the unique thing about this project is the cross-institution collaboration we've set up and how the project is actually being driven by medical student researchers who have taken on board running this project. They've had extensive training, and then they also then do peer-to-peer mentoring and training. And currently we're working across 2 universities. And this work has informed 8 undergraduate degrees and 2 postgraduate degrees to date. And I just want to highlight some of the outputs of the work from my institute. We publish in journals as we are expected to. Our work has been featured in the Lancet series on miscarriage, which is a very influential document in terms of setting policy and direction of in terms of managing miscarriages. We've also helped prioritize and identify interventions for the prevention of preterm birth. This was an international survey with fantastic collaboration and involvement of stakeholders and participants from low middle income countries in particular. We've also produced evidence on the risk of maternal mortality and morbidity in pregnant women with anemia, as well as in pregnant women who undergo C-section. And of course, recent work on the SARS-CoV-2 virus, the effect of the SARS-CoV-2 virus in pregnancy, in terms of how it presents, the risk factors for complications in both the mother and the baby. Our work has a lot of impact. We have informed parliamentary debates on miscarriages, so in terms of policy making. We've also informed the Minister for Science in terms of the direction of the Women's Health Strategy, and the Birmingham Health Partner Review call to action on safe and effective medicine in pregnancy. We informed the WHO work and the COVID-19 strategy in terms of how this impacts on pregnant women. And I've also contributed to global and national guidelines, including the NICE guidelines on the review of progesterone for miscarriage. We've informed the guidelines locally, on the local level, for management of pregnant women or maternal services during the pandemic, and also giving directions on defining the timing of mother-to-child transmission of the SARS-CoV-2 virus as some example. Apart from these regular or expected ways of disseminating evidence, we are also really proud about our the opportunities we try to utilize to disseminate information to the wider public beyond publication and policy documents. We run webinar series. We've run 5 to date on COVID-19 in pregnancy, which have been well attended by hundreds of delegates from 25 countries. The recordings of this are available on our website, so can be reviewed and accessed by anyone. We also hold public and patient involvement workshops where we invite speakers from members of the public or women who have experience of conditions that we may be researching or might be topical at the time. We have interviews and speakers, which again we record and make available on our website, and we produce infographics as well. And our animation on COVID-19, which so breaks down our findings from our publication, is available on YouTube, and is one of the most watched, or is the most watched video from the animators, with more than 100,000 views. We have an active postgraduate and early career medical student researchers base, and these individuals lead and run some of the projects I've mentioned now, and are also involved in setting an agenda for what it is they would like to pursue in the future. So again, we welcome students or anyone who might be interested in studying with us. So that's everything from me. Thank you for listening. So again, I'll be here to have any discussions with anyone. If we could look at ways to collaborate in any future work. Thank you.
Thank you, John. You heroically got through that, and there was quite a lot of sympathy in the chat for your cold. So thank you very much for getting us back on time. That was a great presentation. Some good feedback in the chat as well. So we're going to go into the Q&A session now from the panel. So I think all the panel are going to come back to join us. There you are, by magic. Thank you. So we've got until 1:30 before we go into our break. So I'm going to ask you to be quite brief when you ask your questions. So Kevin and Orkan, there was one question that came up that wasn't really, we didn't have time to address. And then I'll ask you about your future research questions. Sam asked about, there was no mention of physical literacy, i.e. sports and exercise. Is this because physical literacy sits outside health literacy? So Orkan or Kevin, who would like to answer that?
Maybe I can start, and Orkan can, of course, complement that. Health literacy is a very generic concept, and it includes all different facets of health, and that means also physical aspects of health. So health literacy is not focused or limited to a very specific concept. So, of course, this is just the result that we have to focus on well-being, so on the mental health side. But of course, it also includes the physical side.
Thank you. And could you just outline maybe just a couple of research areas of future investigation that you would perhaps be interested in collaboration or future grant capture?
Orkan, would you like to start? I see you're muted.
Adam, can we unmute Orkan?
Maybe
Say
I can start.
Okay, yes, please, Kevin, do.
As you said, I think the most important issue for education context is to align health literacy to the core mission of schools. Then it would be much more easier for schools to do something in the area of health literacy. And exactly here, we have very limited research. So what is necessary, at least from my point of view, is to link health literacy to the core mission of schools, to educational outcomes, and to see if there are any relationships. This would be part of further research. And furthermore, it would, at least for me, necessary to look at how can we combine health literacy with the health promoting school approach? Can we implement health literacy as part of the health promoting school approach? So I would come up with more implementation research. And as mostly health literacy has the problem that we know very good how health literacy is in population groups and where the problems are, but we do not have enough interventions. So we need more intervention research in the school setting.
Yeah. Can you hear me now? You can hear me now.
We can hear you perfectly. Thank you.
Let me just add up to it. I believe that first, it's very important to align health literacy with school topics. This will be a door opener for us to bring health literacy in schools. But also, since we know a lot about health literacy in adult populations and patients, we don't know so much about children, adolescents, or in their role as school students. What is their health literacy? So we need a kind of monitoring mechanism globally to assess the health literacy on continuous basis. And based on that data, we need to develop interventions that are target group specific, addressing the strengths and weaknesses that we have identified by such monitoring mechanism. And in parallel to that, we need something similar for teachers, for school principals, for the whole school and the wider school environment. So that we have a system, a surveillance, a monitoring system in place, generating data on continuous basis in all countries, in all regions, allowing cross-country comparisons and systematic improvement of education for health literacy. So that is something I believe, compared to what we know and what we do with other adults, is something that is much needed.
Great, thank you. I'm going to move on to Hayley now and talking about the built environment. So Adam, if you can get Hayley's mic on, that would be great. Two related questions, if you could be quite quick. One was around, have parents voiced concerns about active travel to school, and does this explain active travel? And then that was from Emily. And then Sam asked, are we seeing the way towns and are changing to take the built environment impact on into health? And Michaela asked something similar. Do you see policymakers, commercial partners and local councils paying more attention to the role of the built environment in health? So just a minute on those, please.
Sure, can you hear me?
Yes.
Good. Passed the first test. So yes, I very briefly mentioned it in my presentation, but parents' perceptions of safety around schools and on that that commute to school is critically important. Obviously, I mean, every country probably varies a bit, but in Australia, you know, schools are generally in a catchment area. They're within a neighbourhood. So technically most children are within walking or cycling distance. There's a lot more we can do around infrastructure, connecting paths, drop curbs, you know, as I said, safer crossings, dropping the speed of cars. But we really do need to change parents' perceptions, and you know, that's a big community shift. We haven't seen increases in crime or child abduction, but parents' perceptions, heightened perceptions of it being unsafe, even to walk as groups and, you know, walking school buses hasn't gone away and is maybe being heightened. So that's a major kind of behaviour change we need to happen at the parent level. Question 2, I think, was around capturing any changes in the built environment over time. I think I took that as, and I think that's a real challenge in built environment health research, is you can't go do a randomised controlled trial. It just isn't feasible. But we have lots of examples now in the literature, and you know, it comes with a lot of funding, but natural experiments are an amazing way, if you've got enough funding and you've got the right timing with those that are putting in that infrastructure, to be able to get that before and after. So natural experiments, and more of them are being done, but they're very difficult to do effectively because of that time, lead-in time, and the funding around that. And I think the third point was around governments. Are they at different levels paying attention? I think it depends on the country and the timing and things like elections, but I do feel that this call, which came from the UK Medical Research Institutes, and then was a partner in funding with the Australian National Health and Medical Research Council, I think that is a great example that we should be flying the flag more of, that internationally there's been a call for more research around the built environment and prevention of NCDs. So I think if it's coming at an international level from multiple countries, that can then filter through. But I would say from a West Australian and an Australian perspective, yes, I believe there's a lot more buy-in happening, but I think it happens when you've got that piece of paper, that evidence that you can give to your decision makers to sway them to where their better investments are for healthier built environments.
Great, thanks, Hayley. And back to John very quickly. We're in the last minute. There's a question from Mohammed. Very interesting presentation. Have you investigated vaccine hesitancy among pregnant women? And we got less than 30 seconds.
Vaccine hesitancy among pregnant women would have to be involved, like some sort of like primary research. Our research methods on the COVID in pregnancy uses already reported studies, so aggregate data. But what we are exploring as well is just ways of reassuring pregnant women on the safety and efficacy of vaccines. So we are expanding that review to include that research question.
Thank you. So I would like to thank all of our speakers. They have been fabulous presentations. They have been so inspiring. I just want to thank you on behalf of everybody. Great questions generated.